And everything I'm going through keeps me sane. I could be the one who'll make you happy, but I could be the one who'll make you bleed. Just pick a cloud and tell me all about it. I'm begging of the moon to know how to be what you want me to be. What you want me to be. What you want me to be. What you want me to
Good afternoon. This is Bryce. You are listening to GenRX Radio on 90.7 WCLH, Wilkes-Barre, Grand Hazleton. Keep it locked.
This is Jamie, and with us we have Dr. Franco, an associate professor of pharmacy practice here at Wilkes University, Nesbitt School of Pharmacy.
Hey, everybody. Happy to be back again.
Yep, we will always have a licensed pharmacy faculty member with us on the show to ensure accurate information goes out to you. We are here to bring you weekly topics centered around the opioid crisis, proper medication use and disposal in not just my community, your community, or our listeners' community, but it is all of our communities. Be sure to tune in every Thursday morning from 9 to 9:30 right here on 90.7 WCLH for new topics and discussions.
So we are happy to be back after a long and relaxing break. Dr. Franco, could you remind everyone of some of the topics we covered last semester?
We covered a lot last semester, and I think especially after having 2 weeks that we were remote, and now that we're back. I think we ended up last semester talking a little bit about stigma and stigma reduction around substance use disorder, and I think especially as we've seen over the course of the last few weeks, everything happening with COVID and COVID going up, that we need to realize that concurrent with that, there's been a massive rise in drug-related death. And a lot of it's tied directly to that. So as we think more about stigma and we think more about COVID, we realize that there's an undercurrent of substance use with that, which we know once COVID becomes whatever it ultimately will become, that the substance use pandemic is still going to be there.
It definitely will be. And so this week, we are going to continue the trend of stigma reduction, but we are going to talk a little bit about chronic pain as well and what it is like to have chronic pain. So this is a little nerdy way of getting into the topic, but over break, I was watching the show called Naruto. And for those of you who don't know, it's kind of like a superhero show, but with ninjas. And the one supervillain, his name was ironically named Pain. And he has this tragic backstory and such, but his whole big thing is that he wants to teach the world what true pain is like. And he even says at one point, if you don't share someone's pain, you can never understand them. And although he's a supervillain, that quote has a little bit of truth. And from the outside, it is really hard to imagine what having chronic pain is like. Everyone, I'm sure, has had bumps and bruises and knows the pain goes away after a while. However, imagine waking up with pain that is 10 out of 10 every morning. That is kind of what chronic pain is like. So that's really the whole point of today's show. We want to educate you about what it's like to live with chronic pain. So, Dr. Franco, I know you're the expert on chronic pain, so could you tell us a little bit about what it's like to have true pain?
Well, I can't tell you what it's like to have true pain. I fortunately, knock on wood, do not have chronic pain. But chronic pain is more than just a symptom. Pain is initially a symptom of something, but then once you're in the chronic stage, which is like 3 to 6 months after you get hurt, you had a surgery, and it's still there, now it becomes its own condition, its own disease that has its own treatments, its own protocols, and it's much more than just ouch. Chronic pain is much more of an emotional experience than it is a physical experience. And treatment necessitates looking at all of those different areas that pain impacts, not just, the ouch part.
Yeah, those are some great points, Dr. Franco. So like Dr. Franco mentioned, it's a lasting pain and can be resistant to treatments. So two different types of chronic pain include neuropathic and musculoskeletal pain. Musculoskeletal pain comes from damage to either bone, soft tissue, or organs. The damage could be due to long-term illnesses such as osteoarthritis or an injury such as a broken bone. The pain could be sharp, stabbing, aching, or throbbing. Dr. Franco, how can we identify and treat people with this type of pain?
Well, you said it there, that identifying it is really around how somebody will describe it. So if it's described as dull or achy or sore, 9 times out of 10, that's going to be a musculoskeletal pain. And you see it with people who get x-rays. If you have knee pain and you get an x-ray and the bones in the knee are rubbing on each other, well, then that's arthritis, and we're going to call it that. As far as treating, the best thing we could do for any type of pain really is exercise. That's the best thing that we could do. All the data says exercise, and I don't mean like CrossFit. I mean just going for walks and trying to get some strengthening exercises happening is the best thing we can do. But as far as medications, you're looking at over-the-counter stuff. Acetaminophen, ibuprofen. That tends to be the best for musculoskeletal type pain.
Okay, great points, Dr. Franco. And I just wanted to hone in on something you said, Jamie. You said how chronic pain can really be treatment resistant. And I know from taking pain with Dr. Franco and from my experience on my rotation, I had a chronic pain patient, and I was picking the doctor's brain about it and talking about the different treatment methods. And I felt like we were going to go in there and we were going to just be like, here are some great options. And she's going to be like, okay. And we were going to get through it like really easy. And then when we went in there, we started talking about all the treatment methods and stuff like that. And just everything didn't work for her. We probably went through like 10 or 15 meds before we found one that she wanted to try and that might work for her.
Yeah, I mean, like, have either of you ever... Well, I always go with this when I talk to people about pain and finding a treatment for it, right? What's your favorite food? What do you guys like to eat?
Chicken wings.
I like hoagies.
Hoagies. Okay, I appreciate one that you call it a hoagie and not a sub, because it's a hoagie.
Definitely.
It's a sub.
It's a hoagie. It's got to be a hoagie. Okay, so what's your favorite type of wing? Like hot wing, barbecue, Parmesan peppercorn? Like what do you put on your wings?
I like the Carolina barbecue.
Carolina barbecue. Okay, and have you tried other types of wing flavors?
Sometimes, yeah.
Okay, sometimes yeah. But before you discovered Carolina barbecue was your favorite wing flavor, you probably tried other stuff.
Oh, yeah, definitely.
Oh, yeah. Okay. And were there ones that you ate it and you were like, oh my God, this is horrible?
Definitely.
Okay, what's your oh my God, this is horrible? What's the worst one?
The worst one, like the super, super hot.
Super, super hot.
Yeah.
Okay, like you will have no face.
Right.
Because okay. That is a lot like trying to find treatment for pain. The downer is you have to try a bunch of stuff. You very well may go through the it's so hot your face is going to melt, wing
Right.
sauce until you get to the one that you like. But when you get to the one that you like, you get to the treatment program that you like, you're like, oh, this is good. This is now my favorite. And I bet you 9 times out of 10 when you go out and get wings, and I'm sorry I'm not picking hoagies because there's only so many hoagies you can really come up with.
It's
for this.
all right, I guess.
Wings are much easier to do this with. That when you go out for wings, chances are you get the Carolina barbecue. And if you see the other ones, you're like, I don't know. I might get it, but I really like this one, so I'm just going to stick with that with
Right.
which I'm comfortable. And that's working with pain. And the hardest part is when we get to people who are down the line where their medications may actually be hurting them more than helping them, getting them to come off of it. Because that would be like telling you really shouldn't be eating the Carolina barbecue sauce anymore. We got to transition you over to, I don't know, Parmesan peppercorn, because that one has better, that one we've shown tastes better long term. And you're going to be resistant to wanting to come off of it because you've been doing it for so long. It's just
Right.
your thing. And that's part of that's honestly the hardest part with chronic pain is trying to get people to come down on meds that aren't working. So hopefully the chicken wing thing
makes a lot of sense.
Good. Okay. That's what we're going
Yeah.
for.
And I really like your example of we're not just using meds too, but we're really trying to use multifocal therapy, so we're trying exercise and maybe meditation and other things, I think it's really important that we use multiple treatments.
It is multiple treatments, and there's no one thing that's going to fix everything. It's not like a sinus infection. You have a sinus infection, you take an antibiotic for a couple of days, and it's over. This? No. And I have another food example for that one. I don't know if you want the other food example for multiple treatments.
Yes, I love these
Oh
food
my
examples.
God. I'm spoiling it all for class. Now you're going to be like, I know what's coming in class because he's going to talk about it. Treating chronic pain is like going to a buffet. When you go to a buffet, what do you do? You go in and you just like house everything.
A little bit of everything.
You get everything that's at the buffet, but you only go up to the buffet one time.
No, I'll go back up and pick my favorites.
There, yes, that's what happens. You go back and you pick your favorites. And that's a lot like treating pain. You have to try everything. And then what happens is people will go back and they'll find the things that worked for them and they incorporate it. But it's also about doing it in the right order. Because much like when you go to a buffet, you don't go up and just get like ice cream and cookies and then also on the same plate have spaghetti. You don't do that. You go and you have to do things in a certain order. Treating pain is a lot the same way. If you do something like exercise first and it causes an insane worse pain situation, you're just going to quit. But if we give you some medications, the right medications, we try to not make the pain go away, but make it tolerable. You go to treatment, you go to physical therapy, say, then it gets better long term. It's the right order and the right things. So there's your, I don't have any more food stuff. It's the chicken wings and the buffet.
You brought up another good point, Dr. Franco, that treating chronic pain isn't going from 10 to 0. It's more likely going from 10 to 2 or something like that. Like the goal of treatment is really to make the pain more tolerable, but it probably won't make it non-existent.
Oh, you're never going to get it. I'll never say never. Like the Eagles did win a Super Bowl, so I'm never going to say never.
Anything is possible.
Anything is possible. Except the Cowboys winning another one. We're just going to never have that happen again.
True.
Right?
I agree.
If you're a Cowboys fan out there, I'm sorry. Nobody's perfect. When it comes to treating pain, getting it down to 0 is almost impossible. But what we really try to treat is function. We want people to be moving, to get up and doing stuff. So if somebody's out there and you're like, I just want my pain to go to 0, that's not what the medical institution's trying to do. It's trying to improve function. So we have to keep that in mind as we start treating people.
Good to keep in mind. So now let's talk about a lesser known part of pain, neuropathic pain. It mainly has to do with damage to nerves, and nerves are messaging cells of the body. They allow communication between the brain and organs. Damage to nerves can interfere with these signals and manifest as pain. Nerve pain typically feels like a burning or stinging sensation. Nerve pain can be due to trauma, but there are also some diseases that cause neuropathic pain, such as diabetes and shingles. So how do we identify and treat nerve pain?
Oh, it's so much more complicated. That's the downer. You know, people will experience what's defined as pain, so some type of discomfort, and go to taking medicines that you could buy over the counter, you know, your Advil and stuff like that. But for this type of pain, this nerve pain, that actually won't do anything. It won't help it one iota. So it really comes down to if somebody has pain that they perceive as burning or electric or zapping, tingling, the first thing they should do is go to a physician. Go to a physician and get checked out, get evaluated so you can get the right diagnosis. Because at least the medication options are much different than what we would do for arthritis or for, you know, a pulled muscle.
So we're going to take a quick break. When we come back, we'll get back into talking a little bit more about stigma reduction and pain. Thanks for listening to Generation RX Radio. Keep it locked on 90.7 WCLH until we return.
Rockin' Northeast Pennsylvania for over 40 years. 90.7 WCLH.
I think that I've fallen out of love with you. I think that I've fallen out of love with you. And it breaks my heart to say that I know we're better off this way. When I first set my eyes on you, was scared you wouldn't like me too. Few years have passed, and I found my way into your heart. Days have passed, we never part. So why did it have to change? Sometimes things turn out this way. Think that I've fallen out of love with you. Think that I've fallen out of love with you. And it breaks my heart to say that I know we're better off this way. And I can't delete, no, the photos that I took of you. But keeping them does me no good. And I can't eat, I can't sleep, I can't move on. So why did it have to change? Sometimes things turn out this way. The things that I've fallen out of love with you. I think that I've fallen out of love with you. And it breaks my heart to say that I know we're better off this way. Yeah, I know we're better off this way. Every night I feel like I'm losing my mind. Each day and each night I can't sleep. And all of the words that you're saying to me, don't they feel right? Don't they feel right? So why did it have to change? The thing that I've fallen out of love with you. The thing that I've fallen out of love with you. And it breaks my heart to say that I know we're better off this way. I think that I've fallen out of love with you. I think that I've fallen out of love with you. And it breaks my heart to say that I know we're better off this way. I know we're better off this way. Yeah, I know we're better off this way.
Welcome back. You are listening to 90.7 WCLH, Wilkes-Barre, Scranton, Hazleton. For those of you just joining us, you are listening to Generation RX Radio. My name is Jamie, and with us we have Dr. Franco, Assistant Professor of Pharmacy Practice, and my co-chair, Bryce. Before we move on, let's do a quick recap of the first half of our show.
We were talking all about chronic pain and what chronic pain is, how we approach it, how we treat it. So I think right now the main thing is we got to continue our conversation about nerve pain and what nerve, or otherwise known as neuropathic pain is, because it's a whole different spectrum compared to musculoskeletal, so like arthritis type pain.
Yeah, so we are here to bring you weekly topics centered around the opioid crisis in not just my community or your community, but our community. Be sure to tune in every Wednesday afternoon from 1 to 1:30 p.m. for a new show. And getting back to nerve pain, let's talk about like diabetic neuropathy. So one of the big things with that is like the diabetic foot ulcers. Like because of the nerve pain, they can't feel, they don't have as much as much feeling in their feet, and so they end up getting these ulcers. So what's something like really important we could do to help prevent that?
Check your feet. That's the biggest thing. There's that line in Forrest Gump where Lieutenant Dan is there, and Forrest and Bubba are in Vietnam, and he's like, rule number 1, check your feet. Rule number 2, don't do anything stupid. So you have to check your feet. People with diabetes, you tell them every day, just like look at the bottom of your feet and make sure that everything's all right. Because you're right, the likelihood of someone with diabetes getting those ulcers in their feet. They can't feel it because of the nerve pain, but there's some blood flow and vascular issues that go into the development of those ulcers. Yeah, you can get really sick if those ulcers, make it their way to the bone. You can lose your foot. So really important, check your feet.
Really important. In pharmacy school, they actually teach you, one of the first things they taught us about diabetic foot ulcers was make sure you check your feet and make sure you keep your feet moisturized so that if you do happen to get like a small cut, or you won't open up the skin because of skin breaks.
Oh yeah, you have to keep it. It's that delicate balance of keeping your feet moisturized, so putting like lotion or something on your foot without making your foot get too damp that you develop some type of fungal infection,
right,
like an athlete's foot happening in your feet. So there is a balance, but yeah, check your feet.
Check your feet. So jumping back into our discussion before the break, one of the most common medications for chronic pain is opioids. Based on 2020 data, for every 100 people in Pennsylvania, an average of 43 people have a prescription for opioids. As we have mentioned many times before, opioids have a risk of addiction associated with them, but for people with chronic pain, these medications improve their quality of life. We want to increase the amount of supplementary therapies, as we talked about before, to help people with their pain, such as exercise and physical therapy, but opioids may still be necessary with some of our patients. For the people currently on opioids, they are just like any other medication and help them live their lives.
So, Dr. Franco, I'm going to steal one of your famous analogies, but one thing you talked about in class is that if you're at your son's baseball game and you take your blood pressure med, no one really notices or bats an eye. But if you take your Percocet to help with some back pain, then you might get some weird looks. So what do you think we could do as a society to kind of balance the fact that opioids do have this abuse potential, but also for people with chronic pain, they are really helpful and almost life-saving medications?
It's complicated, I think is the best way to put that. Opioids, like you said, Jamie, opioids have a place. They absolutely do, and there's times where they're absolutely necessary. They're not necessary all the time, though. And when we look at how the treatment of pain has evolved from, say, the mid-'90s until now, it's very different compared to what it used to be. The mid-'90s, man, we were like making it rain opioids, and now that's not what necessarily is the right thing to do. Are there people who are going to need opioids for the rest of their lives? Yes, there are. And that's for cancer pain for sure, as well as for people who don't have cancer pain, that have chronic pain from a different process. The stigma is the big thing that you're bringing up, though, with how people are viewed, because pain, we can't relate it to anything, or we only relate it to the pain that we ourselves have had, but we don't know what that other person's going through. I just don't understand it. I don't understand the way you perceive the taste of Carolina barbecue sauce because I'm not you. I don't have your genetic makeup or your nervous system. I just understand, or I hear you when you say, I like Carolina barbecue sauce. It's kind of the same thing here. Because it's a subjective condition, you don't really understand it. So it's almost as if you can't look at yourself and say, well, I wouldn't do that, so why are you doing that? That's not how it works. You have to look at it as this is just somebody who's trying to manage a condition in a way that best fits them.
I think it's important too, like you said before, we try to do things in the right order. So like you said, maybe Tylenol or some of our over-the-counters might be an option at first, but maybe eventually we might need to go to an opioid if those don't work. So I think you made some really good points that they still have a place, but they're not our go-to anymore per se.
No, they're just like every medication out there has to be used judiciously. There are criteria to use it, and there's criteria as to when you should continue it and when you should stop it. And just like with medicines for blood pressure or for, you guys are taking infectious diseases right now, so
yes.
You should know how to treat, say, a cellulitis right now. So we're going to give you some Keflex probably just to start you off, but I'm not going to keep you on it forever.
Right.
And just like with that, I wouldn't look at it and go, a cellulitis. I'm going to give you 5 days of Levaquin. Like, we wouldn't, because it just doesn't make sense. Well, it's the same thing here. Does it make sense to give this medication up front? Safe and appropriate medication use. That's the name of the game. If it's safe and appropriate, why should we be worried? We'll monitor it, and we'll just carry it forward. But yeah, not the first thing out of the gate. and not something that most people will need to be on forever. It gets you over that hump of getting into physical therapy and exercising, and then we work to get you down to the lowest effective dose, which may be 0, maybe a little bit more. Everybody's different, but that's how the process usually tends to work out.
Yeah, those are some great points, guys. And I think this is just a good place to bring up the naloxone. Sorry. But I think a lot of people on chronic pain that are on opioids should be getting naloxone. So, Dr. Franco, what do you think we could do as pharmacy interns and as pharmacists to kind of help get people to take more naloxone?
Well, so don't be afraid of it is the big thing. A lot of, when we look at the data as to why pharmacists don't put naloxone out more, because everybody can do it, it's because of it's a lot of fear. It's a lack of familiarity with the products, or it's a fear of communicating about it, or a lack of confidence in talking about it. So just don't be afraid. You got to just cannonball right into that pool. There's a lot of good data and evidence out there on how to talk about it. And in fact, the majority of people who are on chronic opioids, almost 97%, I think, from some recent data, say that they feel comfortable being offered naloxone as a safety precaution. That's it. Not saying they're going to misuse it, but, accidents happen. So we just want to make sure that everybody's being safe with it.
Yeah, definitely. And I know from our experience with just learning about medications, anything from grapefruit juice to just not eating enough food could really alter the way medications interact with your body. So you're right. Having naloxone as that safety bar is something really important to teach our patients about.
Yeah, it's like, you guys been to Knoebels?
No.
Oh,
You're missing out.
you're
Jamie.
missing out. You're missing out. Best theme park food ever. And that's it's better than Disney at times. And you know how much I love Disney.
Yeah, Disney's food is the best.
But okay, so Bryce, the Phoenix at Knoebels, would you ride the Phoenix without the lap bar?
I don't think so.
No, you ride that thing with the lap bar and you nearly fly out of the seat. So naloxone is like the lap bar. You're probably not going to fall out of the seat, but man, if you got some airtime on the Phoenix, aren't you happy that lap bar's there to help keep you in?
Oh, definitely.
Exactly. So that's the way we could try to think about it.
Yeah, those are all some great points. So with that, we're going to start wrapping up our show for the week. But Dr. Franco, will you give us some take-home points?
Pain is subjective. What it is to one person is very different to somebody else. And we realize that dealing with chronic pain is a full disease state. And it's the medications, are necessary and important. They're a vital part of it, but they're not the only part of it. And recognizing that the best data we have is around exercise, and that the treatment of chronic pain necessitates looking at the emotional impact. So things like counseling, strong family support system at home, those are things that are going to be necessary for long-term success.
Thank you for those take-home points, Dr. Franco. So everyone listening, tune in next week, Wednesday, February 16th from 1 to 1:30 p.m. Thank you again for listening to GenRx Radio with Jamie, Bryce, and Dr. Franco. Until next week, keep it locked, right here on 90.7 WCLH.